I'm going to change the topic, but it's another, I would say, busy and complicated for a Saturday morning discussion of a complicated topic. I wish scleroderma was simple so we wouldn't have to talk about complicated stuff, but it's not simple. And so we're going to talk about some complicated areas. And another one that's an exciting possible future therapy called CAR T cells. So the title of my talk is Scleroderma, CAR T cell and New Therapies. And the subtitle is, what the heck is a CAR T? And so I'm going to talk about that. So I'm curious, anybody who wants to just put a notice in the chat or sign up. Some of you heard about CAR T cells already? Is that something that's raised your attention? And by the way, feel free to interrupt or ask questions in the middle of the talk, because even though I'm at the university, there is no test at the end, so we don't have to even get through everything that I'm planning to cover. So I'm curious if somebody wants to raise your hand or just show through the chat system, if you know how to do it, that you've heard about it. I'm curious. All right, somebody at least raised their hand. Okay, good. All right, well, what is a CAR T cell? It's the actual name is too long for anyone to pronounce, so we all call it CAR T. A chimeric antigen receptor T cell, so CAR T cell. And I'm going to, by the way, explain all these things later. This is just kind of covering things as an overview. So it's bioengineering. It means we're changing the cells. We're changing a type of lymphocyte called the T cells, and these CAR T cells are being used for medical research and very much now used for treating patients. It's a hybrid type of cell, so it's not one that any of us are born with, and it's got to be made in the laboratory, and kind of a complicated history. I'll tell you a little bit about that later. It's being used clinically all the time now, every day in clinics and cancer centers around the country to treat lymphoma, which is a cancer of the lymph cells. And it's being investigated for treatment of autoimmune diseases such as lupus and scleroderma. Perhaps not surprising, just to hear this description, it's quite expensive, but we're going to deal with cost at some future time. But right now, very exciting as a possible future therapy for patients with significant severe autoimmune disease. And we want to prevent or treat scleroderma. And so that's the question, is how do we do it, and how do we do it appropriately? And sometimes it needs to be treated aggressively when the disease is aggressive. And so this is an approach with that approach. As you all know, we treat systemic sclerosis or scleroderma in a lot of different ways, and in part because there's a lot of different targets of the disease. There's variable, but many patients have some kind of scarring or fibrosis. The name scleroderma means sclerosis, hardening of the skin because of scarring is essentially that occurs, but there's also scarring in the lung. We call it pulmonary fibrosis or interstitial lung disease. We know, in addition to that, there's blood vessel abnormalities like Raynaud's phenomenon that's so common, but other blood vessel abnormalities that can cause trouble. That's not the same as the scarring. And there's also inflammation, where there's arthritis or leaky tissues that and inflammation. And that's also not just blood vessel and fibrosis or scarring. Those are all three separate mechanisms, and they can be treated in different ways. And so I'm not going to go through the treatments, but again, those of you either with scleroderma or knowing patients know that there's a long list of things we use to treat the skin, gastrointestinal symptoms, lungs, kidneys, joints, etc. But the driver of all this, there at the bottom, we think is autoimmunity. And again, it's the immune system that we think is the primary problem that leads to all the things above. And again, from a clinical perspective, I think many of you are familiar with testing autoantibodies, the ANA test. And what this shows is the fact that the pattern of antibodies from patients that are seen in the clinical laboratory, where if you put the serum from a patient with scleroderma on these cells that are on the slide in the laboratory, you can see these different patterns. And that just shows some of the diversity of autoimmunity in this disease. That one on the right lower part of your screen, the centromere, there's a certain cell structure, and it's very, very characteristic on patients with limited systemic sclerosis, limited cutaneous systemic sclerosis. The anticentromere has that pattern in the laboratory. But patients with scleroderma can have all this diversity of ANAs as shown in the clinical lab, and even more diversity if we look at other kinds of manifestations and other kinds of autoimmune phenomena. But the common feature is autoimmunity. So what do we know about the immune system, and how do we attack it? How do we approach it? So, Dr. Lude already talked about many of these topics as well. I'm going to try to show different aspects of the immune system because that's central to this talk. And I'm wondering, can you see my pointer as I wiggle it around on the slide? Okay.
Yep.
Great. All right. So Dr. Lude already talked about the innate immune system and the adaptive immune system. And he's been talking, and I'm going to kind of talk about that again as well. Innate immunity means things we're born with and don't really change very much over the course of a lifetime. Adaptive immunity means that the body, every individual one of us, changes our body over time to make different cells that actually respond to what we've been exposed to. Both the innate immune system and the adaptive immune system have proteins that are in the blood serum, the liquid part of blood. So, for example, the innate immune system has a group of proteins called complement, and then the adaptive immune system, the main reason that B cells, it's a cell, but their main function is to lead the production of proteins called antibodies. And these are the kinds of things that protect us for tetanus when we get a tetanus shot, and protect us from COVID when we get a COVID vaccine. And we measure these antibodies in the blood. These are proteins in the blood. There are also cells in the innate immune system, the neutrophils that Dr. Lude spent quite a bit of time talking about and might have an important role in calcinosis, but there are other cells. The innate immune system is kind of the first responder because it doesn't have to adapt. It's just there when we're born. The adaptive immune system has another kind of cell called the T cell, and the T cells don't make antibodies, but they adapt themselves to having different kind of function and recognizing different kind of foreign invaders. So all these play a role in host defense, and they all talk to each other through protein chemicals that are secreted by the cells. They're called cytokines or chemokines, but it's not important for this purpose to know exactly what they're called, but you can, think about them as, think about them as hormones for the immune system. They circulate in the blood and they can activate throughout the blood system. So this is kind of something to kind of remember, because we're going to be talking about B cells and T cells as part of the CAR T story. So I want to make sure you understand this basic idea. If there are any questions, again, let me know now. Otherwise, I'll move on. All right. So just in kind of cartoon, the innate immune system, first line of defense. Actually, the first line of defense is that we've got skin that keeps us from getting infected, and we have earwax. Okay, who thinks about earwax? It's protected, but keeps our ears. And we have other things that protect us that aren't actually the immune system itself, but the way that we keep bugs out. But when the bugs get around the barriers, the innate immune cells kind of get going, and they act to clean things up for them. But they need backup. It's not enough. And that's where the adaptive immune system is. So T cells and B cells work as a team. The B cells make antibodies, and the T cells have a number of different functions. Sometimes they help other cells to essentially make those cytokines, make those proteins that signal other cells and help to control them, but they also kill cells that are infected. So killer T cells are going to be part of my topic today. They identify infected cells, and they basically cause those cells to be eliminated from the body. So these are the warriors. And our goal is, can we make the warriors work for us, not just to prevent infection, but to treat autoimmune disease? A lot of other cells to talk about. We're not going to talk about all of them. If you want to get more complicated, if you have about 6 hours and 5 years, we can talk about all the kinds of things. And this is the overwhelming picture, like Dr. Lutz showed. Everybody who does an immunology talk has to say, oh, it's not that simple. Well, if you thought it was simple, of course it's not. The other way to think about it, though, by the way, is all these gray boxes are treatments, because there are so many different pathways and cells and mechanisms involved. Each one of them is a target for a drug or for a treatment or for a cell. So in one way, it's daunting, overwhelming. On another hand, it's an opportunity. Each one of these can be targeted. And in the complexity of treating patients, each one of these is being used to treat patients with autoimmune diseases, including scleroderma. So I'm not going to get into all of that right now, because I can't keep track on a Saturday morning of more than 4 things at once. So here we are. T cells and B cells are what we're mainly going to talk about. And I talked about this already. So these are the immune warriors that are going to protect us. Just to lighten things up a little bit, the T cells are going to be putting on their cape and targeting a target cell and killing it. And they are our heroes. T cells find and recognize infected cells and kill them. And they actually do that sword. They actually punch a hole in the cell that's got a virus infection, punch a hole and kill it. So again, the chemical way in which they punch that hole, another fascinating story, but not today's. But here's the typical immune response. After you get infected or after you get a vaccine, there's the early part of activation where the green light is on. You want it to go like crazy. And then after some time, shown here on the bottom line, the immune response over time, you want to start to regulate it. And then later on, you want to put the stop sign on and have it resolved, and might be left with memory, but you don't want to be actively involved with fighting an infection. Partly you don't need to if the infection's gone. You want to have a memory of it so you're ready to respond next time. That's why we get COVID vaccines and we get the tetanus vaccines and so on. We have both the antibodies that stay with us, but we also have the memory so we can respond better. So we want to, whoops, again, I apologize. Maybe it's too much coffee I've had. I don't know. I'm too activated. My immune system and my hands are both activated. So the other problem, though, is that sometimes we don't turn it off. The resolution part fails, and that's where we get autoimmunity and inflammation. So, as kind of depicted on this little graph, we ask the immune system to do this amazing, almost impossible task. Turn on to any possible infection you've been exposed to ever, and then turn it off without turning against ourselves. That's really a hard process to keep under control. And that's autoimmunity. And the immune system needs help sometimes. I want to get into this a little bit more. So what are we talking about chemically? And antibodies are the immunoglobulins, globulin being a type of protein, and immune globulin meaning these are those involved with the immune system. And all antibodies have a same basic structure where there's a handle part. It's like a Y shape, and the handle was down at the bottom here, and the 2 arms of the Y are the same on any given cell. But the part near the end is extremely variable, called the variable region. And every bug that you've been vaccinated for, or every exposure, or every infection has a variable region that's targeted for that particular protein or particular protein and particular antigen. And we know a lot about the structure. This is if you take an X-ray of these proteins when they're crystallized, we know the detail of the structure, and the technology has gotten so good, we can make an antibody against almost anything that we can have a structure for. If you have a protein, if you have a virus, if you have a bacteria, if you have a self-antigen, we know how to make antibodies against virtually anything. And the body does a really good job on its own. And in the biotechnology world, we can engineer it. And so many of the therapies that are used now for cancer and for autoimmune disease are actually antibodies that are directed against those cytokines, those hormones that are involved with the immune system. So every antibody, every therapy that has an ab at the end, like rituximab, the mab part means it's an antibody. Infliximab, it's an antibody. So Humira, and one of the drugs that's used for scleroderma, tocilizumab, it's one of the only two drugs approved by the FDA for the treatment of scleroderma lung disease. And that is also a monoclonal antibody that was engineered to be directed against something that we want to be able to treat. So we are terrific at making antibodies that can have a variable region that can be targeted against pretty much anything we want. And we've done that. One of those that it targets is B cells, and the therapy that's and the antibody that's the therapy for that is often called rituximab. There are other variations, and rituximab is frequently used to treat patients with scleroderma, and it's targeted against B cells. I'm going to get to that a little bit later. So these are B cells. The B cells lead to the antibody protein production, including the production of autoantibodies. And remember, what we're looking for is an antibody, but the antibodies are made by cells, and they start out with B cells that are early on, and somewhere along the way, the B cell develops this antibody kind of attached to the cell, so it knows what its right target should be, and then it makes that a mature B cell receptor. In other words, makes it so it's really targeted and really binds really well. And then it leads to production of another cell type that comes from the B cell, called the plasma cell, and that's an antibody protein factory. The B cell does all the intellectual work to figure out what to do, and the plasma cell is the Ford factory production that just basically churns out these antibody proteins full time. So when we say we can make an antibody, it also means we're making B cells that are able to be constructed to make the antibodies that we want. And once we have these plasma cells in production, we can make gobs and gobs of proteins that all look just about the same. Okay, so again, B cells and T cells both involved with what we're making for protecting us. I want to spend more time now talking about the T cells. They have different function, as I mentioned. Some of them are about kind of controls, one of them to turn on the other cells. One of them is to control the other cells, to turn them down. The peacekeeper role, or psychologist, the general. And then there's the assassins. These are the killers that I talked about. And these are typically have a surface marker called CD8. Those of you who remember talking about the AIDS crisis, where the AIDS virus infects the CD4 cell, and that has a role as the general. So it kind of makes sense if you have a virus that destroys the CD4 cells that are in charge of basically activating the whole immune system, and you get rid of those, that causes severe immunodeficiency. The target cell that I'm paying most attention to for this talk are the CD8 cells that are so-called cytotoxic T cells that kill cells. So helper T cells, CD4, cytotoxic CD8, and the regulatory T cells. But I'm focusing here on the CD8 cytotoxic T cells that are able to kill other cells, and just in cartoon form. So autoimmune disorders in a nutshell by Beatrice, the biologist. Oh, the lymphocytes or the cells say, hey, there's an intruder, destroy. And the poor autoimmune cell says, wait, I'm one of you. And the problem is that the immune system doesn't always recognize it. And so we have to help the immune system to get targeted. How do T cells know to get activated or not? And so this is getting into a little more technical side of things. But signal number one that activates a T cell to generate whatever it's supposed to do is what's called the T cell receptor. On the T cell, there is another Y-shaped structure shown here that every T cell has basically a unique type of T cell receptor. And that has to recognize the antigen in a cell that's called an antigen presenting cell. And this gets complicated, but basically this cell needs to recognize the specific antigen or the specific protein or virus that's being presented to it, but it also needs something else. It needs another signal to co-stimulate, to stimulate the cells. So the value of that is ordinarily there might be many, many different antigens that a T cell might see, but if it's in a situation where there isn't the co-stimulation, it doesn't get turned on. So part of the way the immune system controls activation and prevents autoimmunity is it requires more than one signal to get things going. And the co-stimulation of the T cells comes from interacting with another set of cells. So these are where these hormones or the cytokines play this central role. So there's this kind of multiple different signals are normally required to activate a T cell. And that's both to make sure it's a good signal that, and also to prevent autoimmunity. So in a cartoon show, this is kind of one way to think about it. The antigen presenting cell has to kiss the T cell in just the right way. They actually have to kiss on the lips. That's this part here. All right, not exactly the lips, but that's the idea, is that it's got to be the right connection. And in this case, there's the hearts in the background. Those are the cytokines that are making this happen. Activating a T cell then is very powerful and requires this kind of set of things together. And so in a cartoon way, this is what happens. Different kind of cartoon, a foreign antigen like a protein or a virus, or potentially an autoantigen, or has to interact with the antigen presenting cell that basically eats it up and then presents it to the T cell in this kissing technique with the co-stimulation that's there. When those T cells get activated, they start to grow and they make more and more T cells. And they also make these hormones, the cytokines, in this case, something called interleukin-2 or IL-2, to activate this whole process and get it revved up. So there's a lot of similarity between the T cell receptor that I just showed you a picture of, that has a Y shape and has this T cell recognition part at the end, and the antibodies that I showed you, that when they are on the B cell is called the B cell receptor. The B cell receptor is actually the same thing as the antibody, but it's when it's stuck to the wall of the cell. And both of them have these other molecules that need stimulation in order to make it really, really happen and get turned on. Well, I've already told you, we are terrific at making B cells and making antibodies targeting anything we want. And we've done that for medically in a lot of different ways. We haven't been as good at turning on T cell receptors for anything we want. Well, wouldn't it be nice to use this power of the B cell, to turn on the T cell to control the B cell, so we can turn on the T cell any way we want. So again, the normal structure of the T cell receptor shown here, with, in this case, a tumor antigen on a cell that's got cancer. And we, in the treatment of cancer, this has gotten very, very far, where we can use the T cell receptor to control a cancer cell. And a major area of success in tumor immunology is finding ways to turn on these T cells. And I'm not going to talk about that because that's not exactly what we're talking about today, but there's something called checkpoint inhibitors, a whole family of drugs, and they're all designed essentially to turn on the immune system of interest. They also turn on autoimmunity. If you turn on all kinds of T cells and you get rid of this need for co-stimulation because you're putting in something that stimulates every cell, you make autoimmunity as well. But it's good for treating cancer. What is also good for treating cancer is if you can make a T cell that targets the cancer cell, but doesn't need the specific tumor antigen to be on the original host cell. You kind of, hopefully, a patient makes the antibody against the tumor antigen. But if it doesn't, you can take their T cells and infect it with a fake antigen receptor, a fake T cell receptor, and have the tail being a very active stimulating molecule, so you don't need those extra signals, the signal 2 and signal 3. So as soon as the T cell sees a target cell that's infected with cancer, it goes crazy and attacks that cell. We make an artificial killer T cell that kills cancer cells. An amazing process. And we know how to do this by making these engineered antigen receptor called a chimeric antigen receptor. The idea of a chimera is it comes from multiple different sources, like the Greek creature that had the head of a lion or the head of a donkey and the tail of a lion, or anyway, there was this a mythological creature that had multiple parts of the same animal. That's what we're doing here. We're making an antibody that's actually or an antigen receptor on a T cell that comes from a B cell receptor, because we can make anything we want, and also turns on the cell automatically so we can kill cancer cells. Very powerful. So that's the value of a CAR T cell, and that is what a CAR T cell is. We can control the target. We control what the cell recognizes by this new T cell receptor that's basically engineered, homemade. We control activation of the T cell by making it self-activating. So instead of needing two signals, it just needs one. As soon as it sees the cancer cell, it goes after it, doesn't need all the rest of it. We can do this by genetic manipulation of the patient's cells in the laboratory. And I'm not going to go into the mechanism for that, but again, amazing work done in basic science laboratories. And by this, we can use the patient's immune system to control cancer and also to control the immune system. So amazing kind of work. So this is used every day in the clinic to treat certain kinds of lymphoma, which is cancer of the lymph system. And by the way, the lymph nodes are where a lot of immune activation and immune part of the immune system. So when we say it's a cancer of the lymph nodes, you can also say it's a cancer of the immune system. So if we can target a cancer of the immune system, maybe we can also target abnormal immune system when it's activated in autoimmunity. And that's kind of where I'm going with this. So CAR-T is used for certain types of lymphoma that fail to respond to conventional chemotherapy. And usually that lymphoma is a B cell, remember the kinds of B cells that make antibodies, that has a cell surface antigen called CD19 or CD20 that's seen in virtually all B cells, including malignant B cells, but also on normal healthy B cells. This target is the same one treated by the antibody rituximab that's being used to treat scleroderma and other autoimmune diseases. Whoops. So the idea is this one. We can use the strongest part of the immune system, the killer T cell, using the knowledge of what an anti-B cell antibody is and how it works, and basically essentially wipe out the B cells, whether they're cancer or whether they're making autoimmunity. And the treatment with CAR-T for lymphoma has been fantastic. As you might imagine, there are risks of killing off all your B cells. And you basically take what ought to be inside a cell and controlled by the cell, and you basically release all this stuff and cause tissue destruction. So remember I talked to you about those hormones that are called cytokines that cause inflammation? Well, if you release them all at once, that causes a storm, and it's called the cytokine release system or cytokine storm. And after CAR-T cell treatment, it's actually pretty common. Usually it's relatively mild, where people just get fever and a little bit achy and they feel like they have something like the flu. But sometimes it can be a very serious illness and can even be life-threatening. So the field of science that's using CAR-Ts is trying to learn how to control that, including a lot of research. And there's also some other kinds of side effects, including one that can affect the brain, because these T cells can get into the brain and cause some things that are off target. I'm not going to go into it, but just to recognize this isn't a panacea that doesn't have some potential risks, even though it's powerful. Also, the CAR-T cells lowers the blood count. That's partly how it works. If you knock out your B cells, you don't have them anymore, and that can lead to infection. So you never want to overemphasize a treatment without acknowledging the risks, and there are some. That said, we've gone from 1987, when the first CAR-T cell was created in a basic research lab, and I don't think anybody felt very strongly that it was going to have a therapy. The first CAR-T cell was approved in 2017, and now there are 6 different drugs approved in the United States for treatment of lymphoma or myeloma that are CAR-T cells. And there are drug companies around the world that are in this business, essentially making CAR-T cells. And these work in the clinic, again, hospitalized and inpatients and outpatients every day. I want to give a little bit of a local story about CAR T cells because UW and Fred Hutchinson Cancer Center kind of have a history in some of this area. The original concept, again, in the late 80s, it was actually first made and being able to control some of this in the early 90s, and then they got to be a little bit better. The first patient treated for with the CD20 with the B cell treatment that's commonly used was done at the Hutchinson by Dr. Press in 2004. And then other treatments along the way with what's commonly used now is this so-called CD19. Both CD20 and CD19 are on a B cell, and they both target B cells, so both used for these lymphomas. And the CAR T using a CD19 is most commonly used now. There are other protocols. The first FDA approval for CAR T for children with acute leukemia and non-Hodgkin's lymphoma came in 2017, and now they're approved all around the world. And this is information borrowed from one of our colleagues at the Hutch, Dr. Jordan Gauthier, who is actually doing research on this. And currently, this is, this is what the patient sees and what the kind of the handouts from the cancer centers look like. A patient would get their blood drawn by a machine that basically gets their T cells and their lymphocytes collected in large numbers, put back the red blood cells and put back the neutrophil cells and put back the serum and plasma. But they take the T cells and grow them out in the laboratory. They inject the bioengineering that allows that T cell receptor to now be in these cells. So here's this new T cell receptor that's present, and they start growing and they expand them. And after a while, they check them out in the lab, make sure they're doing the right thing, and then they grow more of them. And then they take the patient and give the patient medicine so that they'll accept this new T cell and not just get rid of them as soon as they come in. And then they give them like a blood transfusion, and then they monitor the patient to see what happens. That can take a while. And, you know, again, I'm not going to go into it, but it does mean being in the hospital for a while, staying close to a cancer center because patients can get sick. They need to be close by. Again, this is kind of daunting, but it's still accessible therapy. And by the way, this is very similar to another kind of advanced therapy, bone marrow transplant or hematopoietic stem cell transplant that some of you know is being used for treating systemic sclerosis when it's severe, and is actually one of the therapies that's known to improve the life of patients with scleroderma. And I had the privilege of being involved with those studies at the Hutchinson Cancer Center in a national trial that proved that it's effective and something that we still use. And part of the reason I'm excited about the CAR T cell therapy is it's similar to bone marrow transplant in some respects, but maybe a little bit more accessible and maybe a little bit safer. And, you know, we don't know yet, but that's the idea. So with all this in mind, there are many companies around the world that are developing CAR T cells worldwide. Hopefully that means there might be competition, which means that there's hope that perhaps this will work. So if we can target autoimmunity as represented by, you know, autoantibodies on cells, maybe we have a better choice. So is this being used for autoimmune disease? And the first paper that came out about this came out last year in one of the prestigious medical journals, Nature Medicine, using CAR T for systemic lupus. This is a group in Germany, and you can see anti-CD19 members. CD19 was one of the B cell markers using the CAR T for a severe systemic lupus erythematosus, another autoimmune disease that is in the autoimmune rheumatic disease world in a way similar to scleroderma. And their early results show that patients have been treated for up to 2 years with complete improvement in virtually all the manifestations of their disease, including their autoantibodies including their kidney involvement, at least stabilized, and usually not needing any other treatment. And the B cells get wiped out, that they disappear immediately after treatment, but they return to normal after about 3 to 4 months or so. And by 6 months or a year, even though you've knocked out the B cells for a while, they come back, and the ability to respond to vaccine looks like it's nearly normal. So that's pretty good. I mean, that's very good. Now, all this is early. The number of patients treated is still low. There's no long-term outcome, although up to 2 years, most of them haven't been more than a few months. So we don't know enough about this, but it's promising. And also at the American College of Rheumatology meeting that Dr. Lute and I just came back from, there was more information from the German group that's now treated 4 patients with systemic sclerosis, with scleroderma. The longest one has about 1 year follow-up. They've seen improvement in all the patients, and it's been sustained, and it's been quite dramatic. So this is what I think gives us promise. That said, sorry, again, limited information. We don't know yet what's the long-term side effects, what's the long-term effectiveness. I will say that there is one patient with another autoimmune rheumatic disease, inflammatory myositis, dermatomyositis, that was also, or it's actually a variant of dermatomyositis called synthetase syndrome, that was treated with CAR T, had a good initial response, and after about 6 or 9 months later, the disease came back. So it's not clear that this is going to be treating all autoimmune diseases. It's not clear how long it's going to work for everybody, but so far it's very promising. So it's being tried in a lot of autoimmune diseases, especially those with autoantibodies, but even those that aren't. And so you can think about it. Remember, B cells make autoantibodies. Any autoimmune disease that has an autoantibody probably has the B cell involved in some way. If you destroy all the B cells, maybe you can make the autoantibodies go away. I guess as a side note, we don't know in most diseases whether the autoantibodies actually play a role in the mechanism of disease, or are they just a marker for the disease? For example, if you have anti-red blood cell antibodies because you've been transfused with the wrong kind of cell, or because you're having trouble with autoimmunity against your red blood cells, it's actually the antibody against the red blood cell that causes the red blood cells to be destroyed. In contrast, we don't know whether most ANAs actually play a role in the disease, or are they just there as a marker. But if you can destroy all the B cells and the autoantibodies play a role, or even if the B cells play a role independent of the autoantibodies, that could be helpful. What about treatment response long-term? What about short-term safety concerns? As actually in the chat, I see there's a question. All those are real concerns. I've mentioned short-term safety, that cytokine storm, which is a real issue, and that central nervous system problem called ICANS, real issues. The field is, because these are being done so frequently now with lymphoma patients who have the same kind of side effects, there are a lot of clinical investigators working on trying to understand these things better and control them and manage them, but these are real concerns. And what about long-term other kinds of side effects, infections, and other issues? So we will see where this goes, but it's, I would say, has promise and is interesting. So again, what is a CAR T? This is a CAR T picture, and shows this idea that we're taking basically the variability of the immune system to recognize things and doing it in a way where, instead of the immune system controlling both the target and how it's activated, we can use this chemical trick in the laboratory to make the cell with this new kind of antigen receptor, and in a way that's more readily activated by the immune system to target what we want. So what's a CAR T cell? I think I've tried to go through that in the talk today. chimeric antigen receptor T cell, CAR T cell, bioengineered. I haven't gone into the details about that. There are slightly different approaches to doing that by the different companies and different laboratories. But that's kind of off target for what I wanted to talk about today. It's a hybrid cell, basically takes the receptor from B cells or similar B cell kind of approach to adapt it to a T cell, and hybridizing in the sense that we're taking a T cell that normally needs this co-stimulation with signal 2 and signal 3 to activate it, and making it self-activating or more likely to be activated. It's used all the time to treat lymphoma when it's refractory to conventional chemotherapy, and therefore being widely used. It's being investigated for autoimmune disease, treatment of lupus and scleroderma. It's expensive, so that's going to be it's exciting, and we still have to be careful. Don't put the cart before the horse. We still need to know more about it before we jump in to using CAR T. But I think clinical trials are underway in this country and around the world. Someone asked about trials in China. They're being used around the world, and I think most of them are just getting started and not yet up and running, but they probably will be soon. So stay tuned. So those are the things I wanted to talk about. And are there questions? You can ask about any of these cells, but you can also ask about CAR T cells. Lots of possible questions, I would think.
Thank you so much, Dr. Wener. That was fantastic. I do have a question if this would be more of an early intervention, or is this similar to a stem cell transplant?
Yes. Yeah, great question. Early or late in disease. And, certainly at this point in time, it wouldn't be first treatment for anybody. And the clinical trials that I know about getting started will require that patients don't respond to other conventional therapies first, because we want to take patients with refractory disease. That said, don't want to wait till organs are not working well and those kinds of risks. So I think it'll end up being a very similar population to those that we have offered hematopoietic stem cell bone marrow transplant to. That is early enough that there's still active disease and we think there's reason to make a difference, but severe enough and refractory enough that conventional therapies aren't working. So as we get more experience with it, it's quite possible that it would be moved earlier, or if we have better control. Again, also thinking about the context here, in cancer, these are patients who have failed multiple therapies already, and then you use CAR T. Maybe if we don't have to be quite as aggressive with treating. Maybe we use fewer cells or maybe we could have smaller doses repeatedly. Maybe, freeze some of those cells down instead of giving them all at once, so that we have fewer immediate side effects. Or another question that's come in the field, we're giving people a kind of chemotherapy to make them more receptive to the CAR T cells when they get transfused. That's necessary for cancer, but those are cells that are malignant cells. They just keep growing. We got to get rid of them before the CAR T gets accepted. So maybe we don't need as much kind of, in the jargon of the field, the lymphodepletion phase that comes before the cells get placed. So great question. We don't know yet. Right now, the clinical trials are really just looking at safety. We don't know yet. And so nobody wants anybody who's too early, and nobody would enroll anybody that's really kind of late end stage disease. Thank you for the question.
Dr. Wener, I have a question similar to what Christina Becker has put in. And I'm curious about how many times a person can use rituximab, because I'm on rituximab quite successfully. And how hard is that on your immune system? And then looking into the future, can I use rituximab for just prior to a potential CAR T treatment?
Oh, great question. Great questions. So several answers to that. And I should have said this when I mentioned rituximab. Rituximab is off-label to treat scleroderma. It's also off-label to treat lupus. And by off-label, what I mean is that the Food and Drug Administration has not approved it for these indications for autoimmune diseases. That said, they're used a lot, and I think they are effective in many patients. The question of how often can it be used is not answered totally. And by that I mean is there aren't a lot of trials monitoring long-term use to see what outcomes are. But I can tell you in clinical practice, in my experience and seeing other providers, is that we use rituximab repeatedly in a number of patients, often adjusting the dose downward over time so that the way that it's usually used, as approved by the Food and Drug Administration for treating rheumatoid arthritis, is to give 2 infusions of 1,000, if this is for adults now with rheumatoid arthritis, give 2 infusions of 1,000 milligrams initially, then do the same thing 2 weeks later, and then months later, typically 6 months later, offer rituximab again. But the follow-up dosing is not on the FDA label. So sometimes people are using the 2 infusions of 1,000 milligrams. Sometimes they're giving 1 infusion of 1,000 milligrams, and sometimes cutting down the dose to 800 milligrams or 500 milligrams. And part of the reason is that some patients who have prolonged treatment with rituximab, particularly older patients or patients who had other kinds of therapy, the B cells that are depleted by the rituximab therapy that usually in the first dose will come back by about 6 months, 5 or 6 months later, may not come back for several years. And we don't know exactly what the implications of that are. That was a bigger concern in the early days, or even now in a sense in the COVID epidemic, because remember, you need your B cells to make an antibody against something you've never been exposed to before. So none of us had ever been exposed to the virus that causes COVID-19. So patients with rituximab, no B cells, actually didn't respond to the vaccine very well, and often did not respond very well, got quite sick if they got COVID-19 because they didn't have antibodies against the SARS-CoV-2 virus, the virus. We now know that their T cells respond even if the B cells don't, or even if they don't have identifiable antibodies. Remember, there's the 2 adaptive immune system. One of them is the T cells, one of them is the B cells. We measure the B cell antibody function routinely in the clinical laboratory. And even people who don't make antibodies after vaccination do have some kind of a T cell response if they've had something like rituximab. So there's a kind of a balancing act. Is it okay? Is it safe? Well, somebody who doesn't have any B cells coming back, is it still safe? Is there something else we should treat somebody with? So that's one kind of question. And what I would say is there's a lot of, I would say, personal experience that different providers have for how to handle that. And I tend to not infrequently retreat with rituximab and then try to lower the dose over time. And I personally often like to monitor the CD19 or CD20 cells to know where I'm at, but that's not a requirement. It's kind of if you're trying to decide. That's one question. The other question you asked is if you've had rituximab, can you get CAR T cell therapy? Because, and this is kind of this is a sophisticated question. If you already got rid of the B cells, why would you give another anti-B cell therapy? This is an open question to some extent. Different manufacturers and people conducting clinical trials are still deciding whether prior treatment with rituximab is okay, and if so, when, and if so, does there need to be B cell recovery? But there's another part of the coin, side of the question, is that when you give rituximab, the antibodies don't necessarily get everywhere and work. So what we feel now is that one of the reasons that CAR T that's targeted against B cells works better than monoclonal antibodies like rituximab is that those very aggressive activated CAR T cells really go and search and destroy in a way that an antibody doesn't. That one or two antibodies by themselves, the absence of the complement and all the other things that lead to cells being destroyed, they may not work on the B cells that are in the tissues, like in the skin and in the joints and even in the spleen and so on. So that there is this, and we know that the B cells remain even after they're gone, remain in the tissue, even though when they're gone from the blood. Whether CAR T does a better job in that is not perfectly known, and whether that is the mechanism by which CAR T might work better than drugs like rituximab, not really known. So stay tuned. It's a great question. Thank you for asking.
You're welcome.
Anyone know the cartoon of the kid in school? Is my brain full? So I appreciate everybody's coming to our session, and I'm looking to see in the chat, are there more questions that haven't been addressed, or are there more questions from the audience?
Good afternoon. My name is Jean DeBay, and I'm actually from Canada. So I just wanted to ask, are the medications up here in Canada different than down in the United States?
Let's say, are you asking specifically about CAR T cell trials? Is that what, are you asking about that?
I don't really know, because I was just recently diagnosed, so I'm just figuring everything out and finding my new normal. And so some of the medications that people talk about from the United States are totally foreign to me, and it seems like I'm taking things that are different.
I don't know. I don't know the answer to your question in all cases. Most of the drugs I think are the same, and most of them have the same brand names if they're manufactured by, branded with a company. And there are some that are slightly different, I know, but I don't know the specifics of what you're thinking about. But everybody reads, in this era, everybody reads the same medical journals, whether you're from, physicians in Canada, providers in Canada, and in the US are getting the same information. And I can say that the American College of Rheumatology meeting that we were just came from in Southern California included a number of people from Canada, perhaps because it was in Southern California, they came from Canada specifically for the weather, but it was well represented by Canadians. And I know that the Canadian rheumatologists that I know are very aware of these issues and know the drugs. Whether they are available, I don't know, and whether they're the same price, I can't tell you, but usually they cost less. Anybody who's closer to...
Sorry, my government's paying for me, so... Yeah.
I see a question in the chat from Robin, who asks, what does IVIG do in this process?
Yeah, good question. It doesn't eliminate B cells. It's not, one of the parts of that question is what's the mechanism of IVIG, and that's a lot of different mechanisms and sort of controversy and things that we actually don't always know the answer to. I'm trying to get rid of, to stop showing my screen so it's not a distraction. But IVIG works by different mechanisms. One of the things it will do, though, I would say that's valuable to know about in the setting of rituximab, or if the CAR T cell therapy getting rid of B cells ends up leading to the loss of the antibody, the protective levels of antibody, if that were to happen, IVIG is one partial way to protect, replace the antibodies that would normally be protective. Again, one of that's been, I would say, oh, are you still there? Somehow my Zoom quit. Can you still hear me?
Yes, I can.
Okay,
I can
sorry.
hear you, yeah.
Okay, I just got the message that Zoom quit, so I don't know.
Your
I'm not
screen
sure.
share ended, but
Okay,
you can
right,
still see.
that's fine. So IVIG is, again, remember, there's lots of different mechanisms of the immune system, and a lot of different targets, and IVIG is different. It's another topic, basically. Another talk, different talk. I don't mean to go around it. It's just, it's actually, it's not a simple answer for what does IVIG do.
To see the chat because there's a few more questions in there.
Are there tests? I'm sorry. Yes,
Okay.
are there ways to test CD19 and CD20 cells? Yes. Was the last rituximab not effective? Yeah, I mean, rituximab, even if it gets rid of, the short answer is yes, there are blood tests to test CD19 and CD20 levels. Insurance companies may not always want to pay for it, and not every provider feels that they want to measure it because it may not influence what is done in terms of making a decision. I can say that before COVID, I was using rituximab and basically didn't find the need to measure CD19 and CD20, even though I knew that it was depleting because I wasn't going to do anything with that information. I got to measure it much more frequently especially the early days of the COVID-19 pandemic, because I wanted to have a better handle on whether patients were more or less protected from COVID-19 by vaccination. I'm moving away from that now. Again, now that we know that there is the T cell response that we don't measure, and that it doesn't necessarily influence decision to treat or not. But on the other hand, if somebody is not responding at all and the CD19 or CD20 cells aren't being depleted, then I would say it's probably that the rituximab isn't working. And there are a lot of reasons why that might happen, but one of them might be is if somebody is making antibodies against the drug, and if you make antibodies against the drug, then the drug may not work. And so measuring anti-drug antibodies turns out not to be a very good predictor, but measuring CD19 and CD20 cells in the bloodstream after rituximab does say, did the rituximab do its job or not? So that can be done. And routinely done in the same labs that do flow cytometry, the type of thing to look for HIV patients and monitor them, or in monitoring and looking at cancer patients. And then there's a question for you. What about medicines to treat calcinosis? Dr. Lud.
I think I better hand it over to you, Dr. Wener, again.
We've already
We have touched upon it, I think.
We've touched on it. There are many treatments that have been tried, and they include things like tetracycline type antibiotics, to the osteoporosis medicines, to people have tried warfarin. There's some local injections that work, or sorry, not work, that have been tried. Calcium channel blockers sometimes used, control of Raynaud's have been used. I wish I could say that there is one thing that works, and it ends up being kind of trial and error, and we don't have great answers. But in the principles that Dr. Lud mentioned seem to me good principles in general. If we can control the inflammation, then that will prevent things from getting worse. And in that setting, prevent trauma and injury, so repeated injury. So again, when they're on the knuckles and the tips, that's hard. Just wearing kind of a colloid type of dressing that's a little thicker, feels like an artificial skin, or the kinds of blister band-aids that have a little extra thickness, not just a really thin band-aid. Those can be helpful. Controlling Raynaud's can be helpful. But I wish I had a better answer.
Right. No, I think this is all ongoing kind of studies to figure out which one would be better. And the whole field is moving towards what we call also personalized medicine, seeing each individual as an individual and not as a group of patients. So we're trying to learn much more about if we can take a blood sample and learn this particular individual will respond good to a certain treatment. And that's kind of where we are heading towards. And I think that's going to be the case for calcinosis. I don't think that we'll see that calcinosis is one mechanism, but like Dr. Wener showed, so many things happening at once in every patient that we have many targets that we could use, and some of those targets will be more, or mechanisms will be more prominent in some individuals than others. The studies that are ongoing currently, including at NIH, really seem to be focusing in, at least in dermatomyositis, but also in scleroderma, on these novel sets of drugs called JAK-STAT inhibitors. I personally believe that they would be helpful as a new kind of new-ish way of treating calcinosis. They have shown some efficacy, but again, not in every patient. We do summarize some of this in the last year's review on the clinical part of calcinosis and how to treat it. I would be happy to send you that PDF for anyone who wants it. Just let me know and I'll send that over. One thing to also be mindful of is that there are drugs that are counter indications, if you would, for when you have calcinosis, including proton pump inhibitors and stuff like that. There could be other things to be mindful about when thinking about drugs to treat calcinosis, some things to do and some things not to do. But I think Dr. Wener has much more experience about that, obviously, and we'll be happy to send a paper to anyone interested as well.
So the JAK inhibitors that Dr. Lud mentions are approved to treat, many of them used to treat rheumatoid arthritis and psoriatic arthritis and others, ankylosing spondylitis. They're not approved, and there aren't so many trials in scleroderma, but there are some, and they look promising. There has, like every drug, there are potential side effects, including things like that doctors who prescribe and patients need to be mindful about, including some cardiovascular risks that have been associated. So the nice thing about it, though, is that these are oral medicines, and so can be taken as pills and avoid some of the intravenous and subcutaneous injections that are other kind of more advanced. Another practical problem is insurance. These are relatively expensive drugs, even though they're not the antibodies, they're not so expensive to make, but the drug companies have priced them to be equivalent to the monoclonal antibody therapies. And so insurance companies basically sometimes have a hard time paying. I would say strategically, what could the scleroderma committee or scleroderma community do is to get more involved with, unfortunately, but get more involved with some of the insurance company pressure. And, it's this disease is kind of an orphan disease. It's hard sometimes to get trials in large numbers that are going to be paid for by insurance companies, so they don't get FDA approval. So they're considered off-label, and one of the letters from insurance companies, I don't know, some of you might have gotten, I've gotten them for my patients, that this treatment is called investigational. I hate that term when they use it. This is not an experiment. We're using drugs off-label because that's the best we have. We learn a lot from the scleroderma, from the lupus community and the rheumatoid arthritis. And again, one value of being all autoimmune diseases is we learn a lot from one, and we can apply it to the other and back and forth. And for that matter, in the oncology cancer world, we learn a lot from treatments because the basic cell mechanisms overlap a lot. But if it doesn't have an FDA label as being approved, sometimes insurance companies won't pay for expensive drugs. So I'll get off my political hat here right now, but that is something that there is a kind of rare disease or orphan drug kind of approach that can be taken to say we really need to allow scleroderma patients to have more ready access to off-label medications, and that includes the JAK inhibitors. Let's see, a couple other questions. How to use CellCept or initiate rituximab? I'll just say briefly, in general, CellCept comes first and rituximab later, but that's really individualized depending upon the patient and the provider who's making decisions. But CellCept is usually a first line, especially with interstitial lung disease as part of scleroderma. Another question, infection, a tough one. Infection, including this kind of atypical mycobacterial infection. Is it tocilizumab or is it something else? Not always clear how to handle that situation. And yes, somebody talking about insurance denial. Yeah, it's a problem for many of our medications and many of our diseases. Well, I think it's lunchtime. As I appreciate everybody's interest and attention. Excellent questions that were stimulating. I wish we had straightforward, simple answers for some of them. But again, I appreciate people like Dr. Lute are working in the laboratory to try to accomplish what we all want, is this more effective, targeted, reliable treatment based on understanding the disease mechanisms. And Christina, again, thank you for putting this together and for hosting us.
Thank you, Dr. Wener and Dr. Lute. This was really exciting to hear, some information about new research. I think we've heard about some of the same things for quite a while, and these were both completely new to me. So I really appreciate you coming and talking to us and spending part of your Saturday morning with us here.
Any other comments or questions for the group as we leave, or we can all just wave goodbye to each other?